Thank you to the organizers and SITSI and the sponsors for inviting me to speak today on the background on current mechanistic understanding of common toxicities. Here are my disclosures. So immunotherapies come in many flavors. This is not a comprehensive list, but we have vaccines, cellular therapies, as well as immune checkpoint therapies. And you can see that they have different mechanisms of action, but not only that, they also have different side effect profiles. For example, with vaccines, it's common to see infusion reactions as well as flu-like symptoms, very similar to what we see with COVID and flu vaccines. Cellular therapies like CAR T cells give you a lot of cytokine release syndrome or CRS that you can see within hours to days of receiving the treatment. And then you have immune checkpoint therapies, which will be the focus of the toxicities I'll be talking about today. And here we're looking at immune-related adverse events. So the point is, immunotherapies, they're not all the same. So before I go into toxicities itself, I want to go through a little basic background on T cell biology. This is a work of Jim Allison, who ended up winning the Nobel Prize. And in the early 1980s, he actually discovered or cloned the T cell receptor. And you can see that the T cell receptor, when it engages its antigen, it leads to a signal. However, that signal is insufficient in getting the T cell to proliferate. The analogy I like to use, it's like putting a car key ignition. You put the key in the ignition and you hear the motor going, but the car doesn't move. In order to get the car to move, you need to give it a second signal. That second signal is putting putting your foot on the accelerator, and then you get the car to move. So in the same way, Jim Allison discovered that that T cells need a second signal known as a costimulatory signal. The best characterized costimulatory signal is the CD28 pathway, with CD28 constitutively expressed on T cells, and it engages or interacts with its ligands, B71 or B72, otherwise known as CD80 and CD86, that is expressed on professional antigen presenting cells, such as dendritic cells, B cells, and macrophages. So if that's where the story ended, then we'd have a lot of car crashes because you need a brake, right? And Jim understood that, and him and Jeffrey Bluestone independently identified the brake on T cells being CTLA-4. And in fact, mice deficient in CTLA-4 die from a lymphoproliferative disease within 2 to 3 weeks of being born. What Jim then did was he then developed an antibody that transiently blocks the effects of CTLA-4. So it removes the brakes off the T cells. And by doing that, he was able to cure tumor-bearing mice. This then led to development of ipilimumab, which is now FDA approved in melanoma as monotherapy, but also in combination with nivolumab and several other cancers. So after the discovery of CTLA-4 as the first brake, other brakes were discovered, such as PD-1 and PD-L1, and this has led to the FDA approval in many different cancer subtypes. And as I mentioned earlier, this led to the Nobel Committee awarding Jim Allison for his work with CTLA-4 and Tasuku Honjo with his work with the PD-1, PD-L1 pathway in recognizing their work in cancer medicine. So I told you that they're brakes, but I do want to point out they're brakes that have overlapping but also different functions, and that's shown in this table here, and I don't want to go through it, but I do want to point out in red that you will see more adverse events with drugs that target the CTLA-4 pathway as opposed to the PD-1, PD-L1 pathway. And part of the reason for that is because you can think of the CTLA-4 pathway being more involved in T cell priming or activating a naive T cell, whereas the PD-1, PD-L1 pathway seems to work more in the effector phase of a T cell. So when I talk to my patients and I'm telling them the benefits of immunotherapies, and I'm telling them that it's going to boost your immune system to help fight the cancer, I also tell them that sometimes it boosts the immune system to also attack any organ in your body, and that's literally any part of your body can be attacked, or you can have an immune-related adverse event that affects each of the organs in your body. But the more common ones are the skin, the GI tract, and when I talk about GI tract, I'm talking about colitis, which is the inflammation of your colon, or hepatitis, which is inflammation of your liver. And then there's lung or pneumonitis. Should point out that the GI toxicities, especially colitis, are more seen with the drugs targeting CTLA-4, and the pneumonitis is more seen with drugs targeting the PD-1, PD-L1 pathway. In addition, we have endocrinopathies such as hypothyroidism or hyperthyroidism, and that, again, drugs targeting PD-1 or PD-L1 pathways tend to affect the thyroid. And then you have the pituitary, which is the master endocrine organ in our body, and anti-CTLA-4 or drugs targeting the CTLA-4 pathway tend to lead to or can lead to hypophysitis. So these toxicities, you can see that colitis, pneumonitis, hepatitis tend to be very common, unlike in the bottom where you see myocarditis present. But what's interesting is the fatality rate for the common ones is really low. It does happen, but it's low. But what we get scared of in clinic is the myocarditis, which is rare, but you can see has a toxicity that goes up to 40%. So I don't want you guys to think that it's an everyday diarrhea. Like this is actually one of my patients, and I'm going to skip this, not skip, but I'm going to move the slide forward as I talk about it so you don't get completely grossed out. But the point is that this happened 8 years ago to one of my patients. I got a phone call at 2 in the morning, and the patient was in Florida, and this was after he received 2 doses of ipilimumab or anti-CTLA-4. And so the question is, should I go to the hospital? I'm like, yes, you should go to the hospital. But I was able to talk to the ER doctors, and the patient ended up leaving the hospital a few days later. And I just saw the patient 1 month ago, and he's doing well. In fact, his life expectancy was measured to be only about 2 to 3 years at that point. And the fact that he's doing alive and well shows you that these drugs, they can have great anti-tumor effects, but you have to respect their toxicities. With this slide, what I'm trying to show is that these toxicities can happen early, like what you would see with a rash, and that's within 2 to 4 weeks, or they can happen later, such as something like hypophysitis or liver toxicities, where you can see it weeks, months later. I do want to point out that I've seen toxicities as early as 1 to 2 days after receiving therapies, and I've also seen it 1.5 to 2 years later. So you got to, in the back of your mind, these toxicities need to be there no matter when the patient was treated. Also want to point out that these toxicities often happen concurrently, meaning that if you're seeing one, it's not surprising if a patient has another one. So what I ask the team to do, the medical team as well as the patients, is to really do a good review of systems. Once you see one toxicity, make sure that you're not being affected by another. In addition, you should do screening laboratory tests so you can sort of rule out other forms of toxicities. I want to give a clinical vignette of a patient of ours that was treated in our department. This was a bladder patient on a nivolumab monotherapy clinical trial, and this was, I believe, in 2014. So this is a patient that on February 10th received his first dose of nivolumab, and this is a patient who is a heavy smoker and had metastatic disease in his lungs. And then after about 6 days after his first infusion, he complained of shortness of breath to our clinic team, and the patient was from out of state. So we asked the patient to go to the local emergency room to be evaluated, and he didn't do so until 2 days later on February 18th. In the emergency room, they did a CAT scan of his chest, and the report that I read personally said that there were no abnormalities in the chest besides the patient's lung metastases. So the patient comes to our clinic on February 24th to get evaluated for a second dose of nivolumab. At that time, it's determined that his symptoms are related to COPD or his emphysema, and they thought it was a COPD exacerbation. So the patient received a second dose of nivolumab. During this time, I was giving a lecture in our department to the research team about pneumonitis and other common toxicities. And so when the patient came in for his third dose on March 10, the research nurse came into my office and said, I think the patient has pneumonitis, but the treating physician thinks this is a COPD exacerbation. The patient's wife is crying in the room because she's afraid. And she asked me to come to clinic to evaluate the patient. So I asked my colleague for permission to see his patient, which he granted me. I evaluated a patient and I said, I really do believe this could be pneumonitis, but the only way to confirm it is to do a CAT scan of the chest. So we did do that, and I'll show you that on the next slide. And the patient initiated steroid treatment as well as antibiotic therapy, because you never know if someone has a concurrent infection as well, was hospitalized immediately, and unfortunately 2 weeks later passed away. So I want this to be a learning lesson. So this is his baseline CAT scan on the left that shows basically a normal lung with a few lung metastases. And then on the right, what you see is a CAT scan after I evaluated the patient in clinic. And you can see in the bottom, and unfortunately I don't have a pointer, but actually I do, I think. I don't. So anyway, what you can see in the bottom is that there is evidence of pneumonitis. So we're playing Monday morning quarterback here, where I requested the CDs of the CAT scan that the patient had done locally, and that's shown here on February 18. And what you actually, if you see enough of these scans, you'll see that the patient had early signs of immune-related pneumonitis, okay? And so this patient should never have gotten his second dose of nivolumab. And as a result of this clinical vignette, our group will no longer treat a patient unless a CAT scan is done at MD Anderson, because we can't trust the outside scans, or the patient has to bring a CD of their CAT scan so we can look at it itself. And so, so unfortunately, this patient succumbed to the toxicity, which, by the way, in the literature, pneumonitis is thought to be only 1 to 3%. However, our collective experience here, we believe it's really 10%, because if you know how to look for it, you can find it. So one of the things that, so in regards to safety considerations and how do we learn from this, our group has appreciated the fact that these things are underreported, so you need to look for it. Early recognition is important, and that's teaching the medical team what signs to look for. For example, pneumonitis, dry cough, or just shortness of breath are common symptoms that patients report. You have to also educate the patient family to let us know if any of these symptoms are occurring. In addition, like I mentioned earlier, some laboratory tests that won't help you with pneumonitis, but will help you with toxicities such as myositis or the endocrinopathies. And then you need specialists that really understand how to deal with these toxicities so that they can help initiate the treatment, and you'll be hearing from many of these specialists today. Additional considerations our department went into is creating super users, people who are experts in these drugs, and not just talking about clinicians. It's also got to be the nurses and the research team as well. In the beginning, when we were first getting used to these drugs, we were having weekly meetings. Now that we're much more experienced, we've been going more to monthly meetings. We've also standardized algorithms within our department, and now many of the members that are here today with me are actually part of an institutional initiative to try to do this throughout the institution, so that there's one way of treating these toxicities. And then again, handouts to patients are important. There are guidelines that are available. This is an example of ASCO guidelines on how to manage, but in addition, SITC has its own guidelines, but they're pretty similar. I do want to point out that with monotherapies, whether it's anti-CTLA-4 or anti-PD-1 or anti-PD-L1, that the toxicities on the median time to the symptoms is about 40 days, but with combinations, it's significantly shorter. It's about 14 days. And I'm bringing this up because we are now going to triple and quadruple combinations in clinical trials. So we anticipate it's going to be even shorter than that. There are a lot of other immune checkpoints out there. This slide is actually almost a decade old, but I do want to point out LAG-3 just recently received FDA approval. So now there's a fourth immune or break that we're targeting, and so there's many more to come. And again, what I want to point out, overall goals is early identification, prompt intervention, and understanding the biology of the disease. So that the reason for that is that way we can develop biological strategies to actually target these immune-related adverse events, so we're just not giving high-dose steroids for a long time. Finally, there are biomarkers out there. We published one several years ago with looking at CD8 T cells in the peripheral blood, and then another study just recently showed that this happens, or they could detect it in the blood using CD4 T cells. And I do want to point out that it's not T cells. There's also myeloid cells and B cells that can actually contribute to these toxicities. And then my final slide is that we want to be able to re-challenge these patients. And on the left-hand side are all the toxicities that we've seen, or not we've seen, but patients had. And we were able to, with our help of our consultants, get the toxicities ameliorated and then retreat the patients, because otherwise the patients were going to die from their cancer. And we were able to retreat them, and you can see examples of people having clinical durable responses. And so, as you can see, it takes a village to actually take care of our patients and make sure that they're safe. And so, with that, thank you.
Thank you. I'll just see if there's any questions online. So one question is, do you feel that there is negative impact of antimicrobials that are kept on board despite lack of organism isolations?
Yeah, so there's data that's actually coming up from our melanoma group that suggests that if patients are on antibiotics, either prior to initiating immune checkpoint therapy or during their treatment, that they're more likely to have poor responses. In addition, patients who are taking probiotics tend to have poor responses to immune checkpoint therapies, suggesting that the microbiome is the gut microbiome is important. But we need to better understand it because we don't know which bacteria tend to be important. There's a lot of conflicting studies. So there's ones in the East Coast and there's ones in the Midwest and the ones actually here at MD Anderson that they tell you that one bacteria is important than the other. And so it's complicated.